do revert to normal glycemia from a state of impaired fasting glucose or impaired glucose tolerance. About a quarter will progress to diabetes in 5 years, and about 50% would seem to remain the same. But there are some prospective studies suggesting that the figures may be higher than that. So there's obviously going to be a spread depending on which studies you look at. What about screening for prediabetes and diabetes in asymptomatic adults? As I pointed out earlier, type 2 diabetes can be virtually asymptomatic for a number of years before it is diagnosed, and therefore it is pertinent to ask about screening for it. And these are the populations recommended by the American Diabetes Association for whom screening should be seriously thought of. If you have a family history of diabetes, particularly a first-degree relative, if you already have cardiovascular disease, if you have been shown to have an abnormal glucose or metabolic syndrome, people who are overweight or obese, people who lead a sedentary lifestyle, and that could apply to, goodness knows, might be 90% of the population of North America could be defined as leading a sedentary lifestyle. Those with hypertension. I've mentioned earlier the abnormal lipid profile, and I would emphasize that again: high triglycerides, low HDL cholesterol. History of gestational diabetes. I think of gestational diabetes as type 2 diabetes in waiting, and so it's important to focus on those people. And anyone in North America of non-white ancestry. An important category that we're seeing is those who are receiving antipsychotic drugs for schizophrenia and other psychotic diseases. And then there's the traditional one of women who have delivered a baby weighing more than 9 pounds, and also women with polycystic ovarian syndrome. So there's a huge number of patients in whom it's considered appropriate to screen for abnormal glucose or diabetes. And this is ADA recommending that starts at the age of 45. I think one can make an argument that we should even perhaps start before that, because I can tell you when I first came to the United States in 1978 and spoke to my pediatric endocrine colleagues at that stage, if they saw a patient, a young person, child or adolescent with type 2 diabetes, they really became very excited because this was something quite extraordinary. So I stayed in the States for a couple of years, and then I came back and settled in the mid-1990s. And by that time, it was actually becoming much more prevalent. And now my pediatric endocrine colleagues see many more patients with type 2 diabetes than type 1 diabetes. And this really has become a major problem, and we're seeing type 2 diabetes and massive obesity amongst particularly Hispanics and Mexican Americans in the southern part of the United States, in children as young as 5, 6, 7 years old. Okay, so consider testing adults with a BMI of greater than 25 and one other risk factor for diabetes. In the absence of risk factors, testing should begin no later than 45 years. And the ADA recommendation is that if the results are normal, then you should consider repeating at 3-year intervals. And again, this is looking at adolescents in the United States of America. And as I mentioned before, if you look in the middle column where it has the adolescents categorized according to white, black, or Mexican American, you can see that the Mexican Americans have a much higher prevalence of abnormal glucose levels in adolescents than the other groups in America. And obviously, on the right-hand side of the slide, in green, you can see the tremendous correlation with being overweight as well. Huge amount of obesity, unfortunately. So what are we to do about this? And patients, I think, get very bored with us when they ask, what can I do? Because don't you know that every patient who walks in who's overweight and can't lose weight is absolutely convinced, of course, that they're not overeating, and that if you say to them, well, you need to be careful, oh, doc, a bird would eat more than I eat is not an atypical response. And if you know your patient well enough, you can say, yes, I know the type of bird you mean. It's a vulture. But you need to choose your patient before you use that sort of quip. So I think it is a truism that we just have to keep on saying to our patients, the keys to this problem are diet and exercise. Now, are there studies which actually prove this? And the answer is yes. There have been a number of prevention studies looking at type 2 diabetes, and this lists a number of them. The first one at the top is the Finnish Diabetes Prevention Study. It took subjects who had impaired glucose tolerance and randomized them to get a program of diet and exercise which was supervised versus being given advice and then essentially left to their own devices. The U.S. Diabetes Prevention Program also randomized people with impaired glucose tolerance to diet and exercise. There were two other arms in this. There was a metformin and a triglyceride, an arm for each of those, and there was the control arm. And I'll focus a little bit more on the results of these studies. But you can see that, remarkably enough, the risk reduction in progressing from impaired glucose tolerance to type 2 diabetes in each of those studies turned out to be identical, and this was over about a 3 to 4 year period, a risk reduction of 58%. So that's reducing the likelihood of going from impaired glucose tolerance to type 2 diabetes with the intervention was reduced by 58% in comparison to the control groups. Listed below these are a number of pharmacological studies which have looked at can we, because patients, after you go through the ritual of emphasizing that diet and exercise are the keys to things, everyone's looking for a pill or something that will relieve them of the necessity to concentrate on diet and exercise. So obviously there have been studies which have looked at pharmacologic intervention, and I think the interesting thing to see here is that diet and exercise actually did pretty well in comparison to these pharmacological intervention studies, with the exception, if you look, that troglitazone and pioglitazone, and in the DREAM study at the bottom, rosiglitazone, all did very well. So the glitazone class of drugs seems to be the one which has the best track record in terms of helping to prevent type 2 diabetes. But of course, the glitazones have come under increasing scrutiny in recent years, and it is rather paradoxical that the class of drugs which seems to have the best record in preventing type 2 diabetes is also a class of drugs which has a record of increasing weight. Even though the increase in weight that you get with the glitazones is more peripheral fat rather than central fat. But if we look at the Finnish diabetes prevention study, This really shows you